Hi everyone, I'm Mariah and Karen and I are here today to talk about neuromuscular diseases. These diseases affect muscles and the nerves that innervate them, as well as the central nervous system, depending on the disease. Today we are covering ALS, Parkinson's disease, Guillain-Barré syndrome, and MS. Make sure to take good notes as we will elaborate on some of the points. Thanks for watching. Amyotrophic lateral sclerosis, otherwise known as Lou Gehrig's disease, is a relentless degenerative terminal disease affecting both upper and lower motor neurons. So the first part, amyotrophy, basically means muscle atrophy and weakness, and it is caused by loss of anterior horn cells in the spinal cord and motor nuclei in the brainstem. Lateral sclerosis is the degeneration of cells in the motor cortex, causing demyelination of the corticospinal and corticobulbar tracts, resulting in upper motor neuron problems. The lack of motor neuron nourishment is what is leading to the motor neuron death and eventually muscle death. The CNS and the PNS are dysfunctional in this disease, but the causes of the symptoms often look like the peripheral nervous system dysfunction because it is causing dysfunction in the muscles. ALS is the most common form of motor neuron disease, approximately 3 to 5 cases per 100,000 persons. The mean age at onset is 57 years, and men are 1.3 to 2 times more likely to get it than women. It's 90 to 95% sporadic and 5 to 10% familial, which just means it's inherited. The disease begins with distal musculature, extremity weakness, and fasciculation of the muscles. Fasciculation is essentially a twitching from the contraction of muscle groups. You can find a link to an example of fasciculation in the YouTube link below. And then it moves to proximal muscles and eventually to respiration, speech, and swallowing, and respiration is what causes the most death. So ALS has a severity scale out of 10 points with 4 factors: lower extremities, upper extremities, speech, and swallowing. The most severe end in lower extremities is minimal movement or paralysis. In the upper extremities is severe minimal movement and paralysis. Speech, the most severe, is loss of useful speech, either physical or through a tracheostomy. And swallowing is most severe when they're having aspirations of secretions. The systems that are not affected are ocular motion, bowel, and bladder movements. The most common comorbidity with ALS is respiratory failure, and it is the primary cause of death for ALS patients. It's caused by a total paralysis of the spinal musculature and muscles innervated by the spinal nerves. Another comorbidity is depression, and it is situational. Death usually follows within 2 to 4 years of the disease, and there's a lot of loss of independence. There's currently no cure and minimally effective disease-slowing treatments. They do have a drug called Riluzole, and it's the only drug approved for treatment in ALS, providing small improvements in bulbar and limb function, but not strength of muscles. It does extend the life 2 to 3 months. That doesn't seem like a lot, but it is something. The funding for this research and this drug that came out was the product of the Ice Bucket Challenge. So if you partook in that, good job. Non-surgical interventions include dysphagia, dietary treatment, speech therapy, non-invasive pressure ventilation like a BiPAP for breathing. Surgical intervention is the percutaneous endoscopic gastrostomy, and basically it helps them with feeding. 73% of ALS patients have difficulty bringing food to their mouth and eating. There's a palatal lift prosthesis that helps with speech and swallowing function, and then there's ventilation by tracheostomy. I want to make a side note that there is an ethical decision for these patients on extending life with these procedures when nothing is a cure. For example, Lou Gehrig decided to not be put on a ventilator, while Stephen Hawking, who was still alive with the disease, chose to be on one. For alternative intervention, there is cannabis to reduce spasticity, pain, and depression. There's palliative care because there is death is inevitable in this disease. A lot of people start looking for a miracle cure, so they will go to witch doctors and healing pools and just trying to find something for a cure that science can't give them. And then there is technology for communication, which is a really cool thing. Since they still have ocular motion, there's computers that sense their eye movements and they can communicate when they get to the later stages and lose speech. The interprofessional team members include palliative care doctors and nurses, primary care physicians, neurologists, physical therapists, occupational therapists, speech therapists, dietitians, counselors, and nurses, and they occur in settings such as home health, hospitals, neurology clinics, and drug trials. As I said with the progression, it starts at the distal musculature, moves up to proximal musculature, loss of speech and swallowing, and then eventually paralysis of the respiration muscles. Most occupations aren't doable as severity increases and they become very dependent. Death is inevitable, usually within 2 to 4 years from respiratory failure, yet some live 15 to 20 years. For more information or ways you can help, please visit the link below. Thank you. Now I will be talking about Parkinson's disease. Parkinson's disease is a neurodegenerative brain disorder. It is characterized by a decrease in dopaminergic neurons, which are the main source of dopamine, in the substantia nigra, which is part of the midbrain and basal ganglia, and plays a role in reward and movement. In short, a person's brain slowly stops producing dopamine. With less and less dopamine, a person has less and less ability to regulate their movements, body, and emotions. Parkinson's occurs in the central nervous system, and it is the most prevalent of all CNS diseases. 31 to 347 per 100,000 people have it, and the incidence is 4.5 to 20.5. It increases with advanced age, and it's estimated 1 in 3 people over the age of 85 will get it. In the United States, 1 million people have it, and approximately 60,000 new cases occur each year. There's risk factors that include environment and family history, but the cause is unknown. There are quite a few condition characteristics, and I will go through each one and explain it so you understand it better. Rigidity is an increased resistance to movement through the entire range in both directions without the classic clasp knife reflex seen in spasticity. So clasp knife reflex in spasticity refers to resistance to movement in the clasp knife way, and then it gives way at the end. So it doesn't have that. There are 2 types, the cogwheel type and the lead pipe. The cogwheel type of rigidity is basically a combination of lead pipe rigidity with a tremor. Bradykinesia is an inability to initiate and perform purposeful movements, most likely a result of a decrease in activation in the motor cortex. Mycography is exactly what it sounds, small handwriting and handwriting problems. A masked face refers to the picture to the side, the stare, and decreased mobility, and sort of a complacent face, and may look angry or upset. There are postural abnormalities, and they just have a difficult time maintaining posture due to problems with sensory processing and proprioception. Their gait has a decreased velocity and stride length. They don't pick up their feet and they walk in a flat-footed way, so they often have a shuffle. The resting tremor is different from an intention tremor that you will see in MS. This rarely affects activity because it's only happening when they're resting. A common resting tremor is the pill rolling tremor, which there is a link to the pill rolling tremor below, so please go watch that. And resting tremors often are 4 to 7 beats per second. They do sometimes have perception, attention, and cognitive deficits. as well as dementia. They have a difficulty shifting attention, using working memory, and having spatial perception. These are the comorbidities of Parkinson's disease, and it is important to note that some of them are due to some of the medications that they are on. Injuries due to falls. More than 2/3 of all patients with Parkinsonism fall and are at a 9-fold risk of recurrent falls compared with others their age. And at an old age, that can lead to a broken hip and immobility and eventually death. They often have sleep disorders, REM sleep disorder, but that's not the only one. REM sleep is very important because it's the time when the brain does regenerate. They do also have daytime drowsiness, decreased sleep at night, and restless leg syndrome. Dementia does happen in 30 to 90% of patients and can be related to anticholinergic drugs. The low blood pressure is also due to medications. They can have fatigue, fear, anxiety, depression, and pneumonia is the leading cause of death in Parkinson's patients, and it's really due to the decreased activity in general and decreased chest expansion. There is currently no cure for Parkinson's, but some intervention is helpful for their comfort and safety. Pharmacology is helpful in reducing bradykinesia and rigidity, but it's less effective in reducing tremor and posture. The most common form of pharmacology is a combination of L-DOPA and carbidopa. L-DOPA is a precursor of dopamine that is able to cross the blood-brain barrier while dopamine is not, and carbidopa prevents the L-DOPA from dopamine conversion before entering the brain. They are most commonly used together and most effective. Amantadine includes the facilitation of release of catecholamines. There is a surgical approach to Parkinson's, and it involves stereotaxic surgery in precise areas of the basal ganglia called deep brain stimulation, and it may decrease all symptoms and lessen medication, but it still doesn't stop the progression. Alternative intervention, there isn't a lot, but there is a lot of push for early exercise and physical rehabilitation. The disease will still progress, but it will help the symptoms associated with inactivity and falling, and cannabis may be another option for the rigidity. Interprofessional team members include physical therapists, occupational therapists, neurologists, nurses, physicians, exercise facilitators, and can take place in a multitude of settings, including rehabilitation, home health, and hospitals. The progression and prognosis of Parkinson's is seen in the Hoehn and Yahr staging scale for Parkinson's disease. Early symptoms can include sleep difficulties, olfactory loss, and constipation, but the more common symptoms are in the staging scale and usually start on one side of the body. And then number 2, they move more bilaterally, and then posture and reflexes become compromised, and eventually they are dependent on a wheelchair or bedridden. And dementia can be included in the end. As stated before, death is usually caused by pneumonia from the lack of movement or other complications related, but the disease itself does not cause death. It is progressive, but it often takes time. Thanks for listening about Parkinson's disease.
Hi everyone, I'm Karen and I'm going to talk about Guillain-Barré syndrome, also known as GBS. GBS is a rare autoimmune disorder that attacks the peripheral nerves, leading to muscle weakness, muscle atrophy, and in the most severe cases, paralysis. This also falls under a larger umbrella of inflammatory demyelinating polyradicular neuropathies. Now, when I say autoimmune, this means that the immune system is attacking healthy, naturally occurring tissue or substance in the body that's supposed to be there, instead of attacking foreign or harmful agents. This condition is also named after 2 medical students, Georges Sion and Jean-Alexandre Barré, who first discovered the relationship between ascending paralysis and an increased protein count in cerebrospinal fluid eventually leading to what we now know about the immune system's involvement in this condition. The incidence of Guillain-Barré is approximately 1 to 2 cases per 100,000 people. It affects males twice as often as females, and older adults are more at risk. Unfortunately, the cause is unknown. What we do know is that the diagnosis often follows a bacterial or viral infection, and the major takeaway from this is that the immune system appears to be confused and all out of whack after handling a bacterial or viral infection, and only after that are people susceptible to Guillain-Barré. The signs and symptoms listed here are presented in a somewhat chronological order, and that they go from least severe to most severe, and that's also what the progression of the disease looks like. Muscle weakness, tingling in the extremities are what we most commonly see at the beginning, and this happens in both the feet and the legs, and it's on both sides, unlike what you would see in a stroke. And this pins and needle sensation spreads upwards through the body. In 10% of people, these symptoms begin in the face and in the arms. The course of this disease is as follows. Initial symptoms typically present days or weeks after a bacterial or viral infection. The early symptoms, progress and worsen for about 2 weeks until they reach a plateau phase, which is when these symptoms stabilize and remain the same for a period of time. You can stay in this plateau phase for weeks or months. And only after this plateau phase does recovery typically begin. And yet again, this varies greatly from person to person. It can take 6 months to a year to recover, or in the most severe cases, up to 3 years. Most people that develop Guillain-Barré have a really good prognosis. 80% of those affected can walk independently 6 months after being diagnosed. 60% fully recover motor strength 1 year out. Only 5 to 10% have a delayed or incomplete recovery. And children who rarely develop this condition recover a little bit better than adults do. Now, it is fatal to 2 to 12% of people, but this is often connected to comorbidities and less directly related to GBS itself. Now, for more facts and information on what it's like to endure a condition like this, you can click on the link below. The two major systems affected by Guillain-Barré are the peripheral nervous system and the immune system. Perhaps the most important thing about Guillain-Barré is that people recover so well because of regeneration in the CNS. And after all the studying and our recent exams, we know that Schwann cells have a lot to do with it. There are 4 major types of Guillain-Barré, and the major distinction between all these types are which peripheral nerves are affected and how these symptoms progress over time. The most common type of Guillain-Barré is acute inflammatory demyelinating polyradicular neuropathy, and typically we see early symptoms begin with tingling and weakness in the lower parts of the body, and the sensation spreads upwards. In Miller-Fisher syndrome, paralysis starts in the eyes, and it's specifically associated with an unsteady gait later on in the disease. Only 5% of people contract this type of Guillain-Barré, and it's also more common in Asia. The next 2 types of Guillain-Barré are acute motor axonal neuropathy and acute motor sensory axonal neuropathy. These 2 are similar, but there is one large difference. In both of these, the axons are damaged and not just the myelin. In acute motor axonal neuropathy, we only see damage to motor neurons, whereas in acute motor sensory axonal neuropathy, we see damage to both motor and sensory neurons. And why does this matter? Because the symptoms are a little bit different. For instance, with motor sensory axonal neuropathy, we see that reflexes are affected more than they are in just motor axonal neuropathy. This long list here of comorbidities should indicate just how complicated things can get with Guillain-Barré. We have many physical ailments as well as many psychosocial repercussions. Deep vein thrombosis and pulmonary embolism are blood clots in different parts of the body. We have respiratory failure, autonomic dysfunction, malnutrition, dysphagia, pain, skin ulcerations or bed sores from being immobile, contractures, and then anxiety, depression, and psychosis. Psychotic episodes are associated with tetraparesis or paralysis in all 4 limbs, artificial ventilation, meaning the need for a ventilator to breathe, and multiple cranial nerve dysfunction. The implications of this list of comorbidities are that many other systems are indirectly affected, making GBS fatal. It can indirectly affect the venous system, the cardiac system, autonomic system, and the musculoskeletal system. Because GBS is a peripheral nervous system condition, recovery is largely dependent on regeneration inside the body, meaning we don't have all that much control over the nature or course of the illness. But what we can do is try to lessen severity of symptoms, reduce duration, and mainly protect the rest of the body while the nervous system is repairing itself. We can use medicines to reduce pain and prevent blood clots, also SSRIs for anxiety or neuroleptics for psychosis in rare cases. And then we also have two different types of blood treatments with plasmapheresis. With the use of high-tech machines, we're able to remove blood from the body, take out these bad antibodies, and then return the blood cells anew. And we also have intravenous immunoglobulin therapy, which is a blood treatment where blood from a donor is transfused into the body in hopes that new, healthy, different antibodies are able to go in and fight and destroy current, quote-unquote, bad antibodies that are responsible for Guillain-Barré. And both of these blood treatments are found to be equally effective. And then, of course, we have our therapy team, physical, occupational, and speech therapy. In most cases, hospitalization is necessary in the plateau phase of Guillain-Barré. This is where we would have a team of many professionals, and to name a few, we would see a neurologist, a nurse, critical care doc, pulmonologist, and then different types of therapy professionals. Looking forward at the larger picture and our understanding of Guillain-Barré, there's current research on the connection between Zika and GBS. We're seeing incidence rates that are about 4 times higher than what they normally are, where Zika outbreaks are occurring. Brazil recently reported an incidence of 7.5 cases out of 100,000 people, as opposed to the standard 1 to 2 cases. And there's a total of 15 countries reporting higher incidence rates right now. So this is currently being investigated. The second study is the role of the central nervous system. Guillain-Barré has always been thought of as a PNS condition. However, from time to time, there are case studies where patients present with lesions in their brain, specifically the frontal and occipital lobes. So this too is currently being investigated. The next condition I'll be discussing is multiple sclerosis, also known as MS, and this literally means multiple scarring. Multiple sclerosis is an autoimmune central nervous system disease that's chronic, degenerative, inflammatory, and demyelinating. The immune system attacks the oligodendrocytes, also known as the cells in the central nervous system, myelin, and neurofibers. Inflammation and scar tissue take the place of destroyed myelin, causing plaques, aka lesions, in the brain and spinal cord, preventing signal transmission. There are 200 new cases of MS diagnosed a week. It affects approximately 350 to 400,000 people in the US and over 2.5 million worldwide. It affects women 2 to 4 times more than it does men, and although men develop this condition less frequently, their progression is typically more aggressive and they have a worse prognosis. The average age of diagnosis is 32, but the window of onset is between 20 and 50. Now, the prevalence and these statistics are somewhat debated due to challenges related to promptly and accurately diagnosing people with MS. Unfortunately, and similar to Guillain-Barré, we don't know all that much about the main causes of MS. What we do know is that people are genetically predisposed to develop this illness, and there also seem to be some environmental influences that are currently being studied. Here we have a long list of signs and symptoms associated with MS. This should indicate how different every case is, and no person with MS looks like the next. The most common early symptoms are muscle weakness, tingling sensation, numbness, blurred vision, and painful eye movements. This is because MS is known to affect the brain, the spinal cord, and specifically the optic nerve. Lower down on the list, we have more severe symptoms that develop over time. And for something like cognitive issues, we typically see problems with memory and problem solving. MS is a degenerative condition, meaning it gets worse over time, but it's also seldom fatal, so fatality rates are more connected to comorbidities than the actual diagnosis of MS itself. The course of the illness is marked by good and bad days. The bad days are what we know as flare-ups, or exacerbations, attacks, or relapses, which are other names for flare-ups. This period of time is when symptoms get worse or new symptoms present. Following this, we see remissions, and that is periods of reduced or very few symptoms. Triggers for these flare-ups vary from person to person, so it's somewhat unpredictable. And these people have a similar life expectancy as the general population. They experience pain and discomfort throughout life, but the real takeaway is that this condition affects quality and not longevity. There are a few different factors that can influence the course of this condition. One may have a better prognosis if they exhibit fewer symptoms in the beginning. There's more time in between each flare-up. Symptoms are related to sensory as opposed to motor problems, and they recover well from these flare-ups. One may have a more aggressive course if they're over 40 at diagnosis. Their initial symptoms affect more than one area of the body, and the initial symptoms affect cognition, urinary, and motor control. MS affects the central nervous system, the peripheral nervous system, and the immune system. Unlike Guillain-Barré, we don't have regeneration in the central nervous system. So when our immune system attacks our myelin or nerve fibers, scar tissue and inflammation develop instead of regeneration. This is why people do not recover, and we consider this a chronic disease. Lack of regeneration is also what explains progression of symptoms from least severe to most severe over time. There are 4 major types of MS, and the difference between these 4 are the progression of symptoms. The most common form, called relapse-remitting, is found in 85% of people. New symptoms appear during these flare-ups, and this develops into the second type, called secondary progressive MS. This second type, we see that symptoms worsen more steadily over time, and these people may or may not have remission periods, which are periods without any symptoms. Primary progressive, the third type, is found in 10% of people. Symptoms slowly worsen from the time of onset, and typically they have no remission periods. The fourth type, called progressive relapsing, is found in 5% of people diagnosed. This is the most severe form, and it's also the most rare form. Symptoms steadily worsen from the time of onset. We see acute flare-ups and no remission periods, and these people may or may not recover function. Comorbidities of MS are fibromyalgia, or widespread muscle pain and soft tissue tenderness, inflammatory bowel disease, epilepsy, which is seizures. This results from abnormal electrical discharges in scarred or injured areas of the brain. This is uncommon, but it does happen. And then we have bipolar disorder and depression. People with MS have a high risk of developing emotional disorders due to complex interactions of factors. For instance, depression can directly stem from damage to neurons that send messages affecting mood, but depression can also be a side effect from other medications, and it can be a psychosocial repercussion of difficulties related to MS. It's also believed there's a genetic predisposition to many emotional disturbances. Finally, bipolar disorder is reported in 13% of people with MS. The implications of these comorbidities are that other systems are indirectly affected, and these other systems that are affected are what ultimately lead to MS becoming fatal. It's also been found that suicide is twice as common in people with MS as the general population. There's currently no known cure for MS, unfortunately, but our intervention goals are about reducing discomfort associated with symptoms of MS and other comorbidities and slowing progression of the disease. We can use medications such as anti-inflammatory drugs, immunosuppressive drugs, and interferon beta drugs. All of these are somewhat effective. Plasma exchange is a blood treatment, also known as plasmapheresis, where we swap out bad antibodies for good, new, healthy antibodies that help our immune systems. We have deep brain stimulation. This is a risky procedure, and it is intended to treat intention tremors. This involves sending shocks to different parts of the brain non-surgically, and we find that shocking the thalamus with MS is the most effective. We also have something called chronic cerebrospinal venous insufficiency surgery. This is controversial, and chronic cerebrospinal venous insufficiency is a new theory for the underlying cause of MS. In 2009, a doctor in Italy proposed that nervous system dysfunction is connected to abnormal blood drainage from the brain and the spinal cord. Now, to treat this, we go in and we open up blocked or narrowed veins by inserting a small balloon or stent to allow better blood flow. Like I said, this is controversial and also inconclusive evidence for the cause of MS. We have acupuncture, Botox, counseling, and of course our therapy team of OT, PT, and speech therapy. Most MS patients are treated in outpatient rehab centers. However, when symptoms flare up, hospitalization may be necessary. Just a few of the people that MS patients work with are neurologists, neuropsychologists, social workers, nurses, and of course our therapy team of OT, PT, and SLP. This slide here gives you an idea of some of the major research topics that are being studied in connection to MS. As I mentioned earlier, there's speculation that the cause may be environmental influences as well as a genetic predisposition. Some of these environmental influences are exposure to sun and vitamin D, and we're seeing that rates are higher further from the equator. The second topic is autoimmune versus immune mediated. Because we have yet to identify the specific antibody associated with MS, scientists are referring to it as immune mediated as opposed to autoimmune. Also, statistics indicate that this condition is on the rise. However, this could be related to disease awareness, many more diagnostic tools than we used to have, and an overall better access to medical care for a lot of people. So this is also inconclusive evidence. Finally, there's an international initiative on comorbidities to try to understand a lot of the complexities that arise with this condition. So this is the end of our presentation. We hope you guys learned something, and we're looking forward to answering your questions. Thanks.